So when you knew that there would be a teaching about NIV, what was the main thought that came to your mind? Like, give me one thing that you know or you expect to be covered today. Come on. Where are all the SHOs? No one.
It would be good if someone speaks up, because Ahmed's clearly gone to a lot of effort here, so it just makes it a bit more interesting and interactive if someone can speak up. You can say what you like.
The indications and types.
Okay, so types, and what was the other thing?
Indication.
Indications, wonderful, yes. So first of all, yes, yeah, I agree with Dr. Sabir. Let's set some ground rules first. So the ground rules will be mainly interaction. This is teaching. So like, I'm not going to be talking on my own today. All of us will be talking. The other thing is, if you can, please, cameras on. That will help me. As fascinating as it is to talk to your black screens, but I would prefer to see a bit of faces. So thank you very much. That's all for now. The thoughts, yes, it just to help you guys concentrate. I'll start this video. Focus. If you know the correct number, I'll give you a chocolate bar. How many?
Yeah, my answer was 14.
14.
Yeah.
Did you see the gorilla?
Oh shit, no. There was? Oh yes.
Yes, this is the gorilla. It's a very interesting video actually for like how our attention is selective to things. So mainly these are the objectives that I'll try to cover today. What's NIV, CPAB versus PAB, an indication of NIV, contraindications or when not to use NIV, complications or the side effects that can happen with NIV, and how to set up a machine. I'm not going to go thoroughly on that, but because it's completely different according to which machine we're using, but just the general idea of the connections and what to do when you need to set this up. Okay, let's go to NIV. So NIV is non-invasive ventilation, and the idea of providing support to a patient without putting a tube down his or her throat and providing a bit of pressure is not a new idea, actually. It started between 1920 and 1950, around the time. Do you know what is this? Not you, Dr. Sabir. Do you know what is this? This is the iron lung. The iron lung was first introduced in between 1920 and 1950 during the polio epidemics that happened around the world. And the main idea is to apply a negative pressure on the chest from outside, which is still there actually. It's not obsolete, like still there, but it's not around very much as the regular NIV. And we mostly use it for patients with very weak chest muscles, like patients with motor neuron disease or patients with very bad COPD. So that's the first time an NIV-like idea was used. We have two modes of NIV. So usually when we say NIV, people go more or like mean subconsciously the BiPAP, which is the 2-level pressure, but actually NIV is the CPAP part, which is we'll talk about in a minute, and the BiPAP part, which actually we also will talk. So the CPAP is the continuous positive pressure or positive airway pressure, which is very straightforward mode. We set a certain pressure which we want to achieve or we want to keep continuously in the airway. I'll come to this in a minute. And so at all the time, there will be a fixed pressure in the airway. This photo is actually not in like absolutely correct, because the expiration and the inspiration pressure during CPAP, even during CPAP, is not fixed. It's not the same. This means that the pressure offered from the machine is the same, but there will be fluctuation in the pressure, but that will be triggered by the patient. The patient will be adding pressure by his breathing, but the machine is not going to add any extra pressure. That means that the pressure offered is fixed during the whole time of the respiratory cycle. While in BiPAP, we have 2 levels of pressure. Okay, so you can see here that 2 modes, which is the normal breathing, which is here is not entirely correct, because there is never a zero pressure in the airway or in the lungs, because the lung will collapse. We can go a little bit up on the pressure value, which is what we call the intrinsic PEEP. The intrinsic PEEP is actually the pressure that we will keep in our lungs at the end of expiration, trying to achieve or trying to keep the lung open. And it's usually happening because of the closure of the vocal cords and the glottis. So that will keep a little bit of PEEP, usually maybe around 3 centimeter water. And that's why when we try to add extra pressure, we'll go a little bit higher than that, maybe 5 or more, to give the patient a little bit more than the intrinsic PEEP, which is the CPAP. And you can see here that there is fluctuation in pressure all over the cycle, but the amount of pressure offered for the machine is the minimum, or like the continuous, which is usually like in the form of added PEEP to the patient. And in BiPAP, you can see here that we have EPAP, which is the expiratory positive airway pressure, and the IPAP, which is the inspiratory positive airway pressure. And the EPAP here is just a fancy word for PEEP. So the EPAP here will be the amount of PEEP you're offering the patient, and the IPAP will be the EPAP, which is the PEEP, plus the amount or the difference in pressure, which is the pressure support. So when we try to do that on the machine, we don't have usually portable NIV machines, but we have like the regular ventilator was with an NIV or a BiPAP mode. You'll find that you will set PEEP and set pressure support. PEEP is your EPAP, and EPAP or PEEP plus the pressure support, the outcome or the sum of them is the inspiratory uh, positive airway pressure. Okay, so indications. When do you think we need to use CPAP? Waiting.
Type 2
2.
respiratory failure.
CPAP. Type 1 or 2?
2.
2. Okay, I would say keep type 2 for BiPAP, okay, and type 1 for CPAP. I'm not going to go into details in the respiratory failure details, but we'll keep it for the coming session. But for CPAP, we mainly go for type 1 respiratory failure, which we try to address hypoxemia mainly. These are parts of the indications that we can use CPAP in: pulmonary edema, sleep apnea, Pickwickian syndrome, which is the obesity hypoventilation syndrome. By CPAP, we want to improve oxygenation mainly. Does it help with ventilation? Minimally. Why? Because we don't add extra pressure to the PEEP we're offering the patient. We're trying to improve the amount of pressure inside the alveoli to keep it open, improve oxygenation, and like reduce the mismatch in the ventilation perfusion curve. So this is actually the indication of CPAP. On the other hand, for BiPAP, we need to add an extra pressure to support the ventilation of the patient. So usually we use it when we have hypercapnia or type 2 respiratory failure to improve the ventilation in these patients. For example, the COPD patients, especially COPD patients with type 2 respiratory failure and the retention of CO2, patients with the motor neuron disease and patients with muscular problems, the BiPAP will be helping, because if you look at it, the amount of pressure you're offering in CPAP is just so close to the natural pressure you're offering in these patients. So your main aim is just to keep the alveoli open and improve the oxygenation and the gas exchange part. But when you go for BiPAP, this is the patient when the muscles are not working, the lung structures are horrible, or as horrible as in COPD or ILD, for example. So we have both, like the oxygenation part and the ventilation part is impaired. So we need to give extra pressure, and that's the whole idea of BiPAP here. So we have started CPAP or we have started BiPAP, but is it working? What will be the parameter we will go for to know if what we're doing is working, or the next step I'll call my consultant or my registrar and saying, I think this patient might need intubation, or this patient at the ceiling of care, so we're not going anywhere. What do you think? Like, what are the parameters you will look at?
Gas, CO2, and the gas, the CO2, and the O2 levels.
Okay, yes, CO2
With
and
the work of breathing of the patient.
Thank you very much. The work of breathing. So in type 1 respiratory failure, especially when the patient is hypoxic, they will start being dyspneic and the work of breathing will increase in both of them actually. But whenever we fix the hypoxemia part and whenever we support the ventilation process of the patient, that will make them less less dyspneic, and the work of breathing will decrease. So these are the parameters. We will look at the patient clinically in the bedside, and we will look at the saturation we're achieving. We'll look at the gases. Of course, the gases are very important, and not rely so much on the saturations, because sometimes that might be tricky. The saturation can take some time to fall, and it's not going to reflect if the patient is hypoventilating or the patient is getting tired or not. So this is very, very important actually to look at the big picture and not just on the gas or not just on the saturation or one aspect of it. Look at the whole or the total picture. So we decided that for these patients, we're going to use the NIV, but when we are not going to use it, like when NIV is contraindicated or probably not helping so much if being used, these are the part of the contraindication of the use of NIV. Pneumothorax, which is controversial because sometimes during pneumothorax we can still use NIV or use, for example, CPAP. But I would say undrained pneumothorax might be, or tension pneumothorax might be a contraindication because of the pressure dysregulation inside the chest, which mainly will affect the cardiovascular component of the things, and of course will also affect the breathing of the patient. But pneumothorax, I wouldn't say completely contraindicated, but it will be patient by patient. Whenever you have a patient with pneumothorax that you think might benefit from CPAP or NIV, please talk to your consultant or your registrar, and you can think about that. Facial trauma, if you have a patient with facial trauma, recent nasal surgery, any fracture in the face, traumatic patient, be very careful using NIV because of the sealing of the mask on their face. Patients with increased intracranial pressure, that's very, very important because the pressure from the mask might trigger agitation, might trigger hypertension, and might trigger increased intracranial pressure as one of the complications of NIV. So be very, very careful with that. Patients with recent gastro GI surgeries, be very careful because of the aspiration of air or the swallowing of air that might affect the site of surgery and might inflate the stomach with air. So be very careful, especially patient with like bariatric surgery like gastric sleeve. Be very careful with these patients as well. And low GCS patients. So non-invasive ventilation is mainly offering a bit of support for patients who are spontaneously breathing. If your patient cannot maintain the airway at risk, or the patient is hypoventilating, for example, a patient with TCA or opiates overdose, they will be hypoventilating, still spontaneously ventilating, but the amount of breathing they are achieving is not enough for them. So just be very, very careful with these patients because you might give them the NIV, but that won't help because you need the patient to be like breathing to get benefit of the pressure you're offering. And if the airway is at risk, that's very critical and might be fatal for the patient. So just be careful. Complications. So what do you think are the complications of NIV? When you're giving the patient NIV, for example, BiPAP or CPAP, what might be the complications?
You've all seen NIV news. Just somebody say something just to make it a bit more interactive. Otherwise, it's just Ahmed talking to us. But it's a lot more interesting when it's a bit more interactive.
Ahmed, there could be injury. Yeah, there could be aspiration, injury. Those are the main ones.
Yes, injury. What injury you mean? Like lung injury?
If it's not a well-fitting mask, you can get pressure sores and pressure
Exactly,
injuries
thank you.
around the
Yes,
nose. And
facial injury is one of the things, like especially pressure ulcers. What else? And yeah, and yes, you said the aspiration part. Patients on high flow, like high pressure flow, so they can swallow this air, and that might cause aspiration, especially if they are confused. What else?
maybe it's not well tolerated, and if you tend to give sedation to the patient, you might, for him to accept it, your level of consciousness might be deteriorated in that sense.
Yeah, of course. Okay, so the complications of NIV can be one, pneumothorax. We're giving the patient high pressure airflow, so that can increase the pressure inside their chest, and especially in patients with who will need NIV for a long time, like COVID patients, we usually try to give them all the chance on NIV before considering intubation because of the like not very favorable outcome of that. But pneumothorax might be because of the high pressure. Facial ulcer, thank you, you mentioned that. Secretion retention, like you're giving them pressure and they have secretions, they're trying to cough, but they might be a bit weak. The amount of cough or the amount of pressure that they can um, trigger is not enough to go against this pressure. So that's why we need regular care. We need to remove the mask and like do some suction if applicable, or just if they are coughing, we can remove the mask and give them some time on the nasal high flow. Again, if applicable, it will be patient by patient. Eye irritation, yes, the seal and the tension on the face can cause eye irritation. Even if the patient has glaucoma, that might trigger intraocular pressure to be very high, aspiration, and anxiety, agitation. That's very, very expected. The patient is feeling like if the patient especially is claustrophobic, that will be a disaster for them. The patient might aspirate, the patient might have impaired communication, of course, impaired nutrition. So in these patients, we might need to think about breaks of nasal high flow, if applicable, and give them food. If not applicable, we might think about NG tubing them and giving them nutrition through the NG tube. Like, think about what might happen to your patient and accordingly act on it and try to fix the complication that happening. Machine setup. So the machine setup is very usually straightforward. Like, to be honest, you don't need to think a lot about it. Just go to the bedside and ask one of our nurses who are very, very good in these things to show you the how they like set the machine up, how they use the connections, what is connected to the machine, what's connected to the patient. Usually on ICU, what I have being used is the mask, the nose and mouth mask, but there are a lot of variations in the mask we use for the patient. So we can use the full face mask, we can use the hood, which is like a complete hood on the face or in the head. We can use the nasal mask, which is usually for CPAP patients with sleep apnea. But again, it's a bit tricky because if the patient is a mouth breather, it won't benefit them so much. So you need to like prompt the patient how we use it and give them the instructions about close your mouth and just use it from the nose. Usually we don't see this around much in ICU. I haven't seen it in 9 months now. We usually use the full, like the regular face mask or the full face mask. These are like the mask types, and this is just a very quick video that is explaining the connections of the tubing, which is actually very, very good. And to give you an idea about what we do and what kit we use, it might be a slightly different kit we have here, but we can demonstrate this or can see this in the bedside.
So first thing is our ventilator tubing.
I can't hear anything, Ahmed.
Yeah, the voice is not very audible in this video. You are on mute, Ahmed, I think. Ahmed, we can't hear you. You are on mute.
Yeah.
So it's mainly explaining like the connection we use, like the tubing for the NIV. And usually the one they are using here is a portable NIV. So it's a machine only for NIV. Usually in ICU, we use like the regular ventilator. Just change the setting to NIV or CPAP to be used. The tubing or the connection they are using is like prepared tubing or a ready tubing to be used. The one of the things that we should be aware of that NIV or is an aerosol generating procedure, so we should be very careful, especially if we're suspecting any like infection. And now, if we're suspecting COVID, we should be careful and we should be in full PPE. The other thing, use of a viral filter, which we usually do for every patient, but just be very careful if you're changing connections or changing machines to keep a viral filter on the machine to like decrease the risk of infection. And on the, just a second.
Or for pipe.
on the machine, if you're sitting like I said before, if you're sitting CPAP mode, you will sorry, you will set PEEP and pressure PEEP only, and that will be your CPAP mode. And if you're sitting BiPAP mode, you set PEEP and pressure support, and accordingly assess your patient clinically, assess the gases within 30 minutes or 1 hour, and then accordingly change the amount of pressure you're offering to your patient. Okay, so any questions? Questions.
Was that the end of the talk, Ahmed?
Yes.
Okay, so any questions for Ahmed? Any at all?
Okay, that
Okay.
means it was a
I'll
very
ask you a question. Tell me
okay.
about we went over some of the indications about type 1, type 2 failure.
Mm-hmm.
And I think you also mentioned sleep apnea.
Mm-hmm.
Tell me about, other than the nasal trauma and the irritation, what do people think about the physiological consequences of NIV?
So it's the NIV will mainly increase the increase the pressure inside the chest cavity, and that will physiologically on one side, on the cardiovascular, on the vascular side, it will decrease the venous return to the heart. So that's why these patients, if not properly filled, might get hypotensive. So we should be aware of that. That's one thing. The other thing is, yeah, I've mentioned that on the the respiratory part, it will keep the lung inflated.
And other than you, Ahmed, I'm going to ask the other people that are sitting there silently. Sandhya has already contributed, and I saw somebody else. But anybody else would like to comment? What are the some of the physiological changes that we have to consider when you're doing using NIV? We've spoken about, if you have somebody with CPAP for a long time, while it can be quite claustrophobic, it can get very hot. You see these people, certainly when it's humidified, they get quite hot and sweaty, and they find it uncomfortable. They're already struggling to breathe. It helps them, their oxygenation. And obviously, if it's on for a long time, one, people have different sized faces, and you don't always get a seal. Now, unless it's sitting properly, it's just not that effective. So if I'm over on the ward, I always try and put my hands around to see how much of a leak there is, and I'm always readjusting it. But invariably, when the patients are moving, it always gets moved again. But you really want to have a good tight seal. Anyway, if it's on for a long time, as you quite rightly said, you get a bit of pressure sores on the nose, and it can also irritate the eyes, because it can blow a lot of dry air up into the eyes, and people find it a bit uncomfortable. But what else? I'm talking more about physiology now. I shall pick on you. Okay, who's MB?
Hi, Doctor. So basically, what happens, especially,
can you just tell me to put your camera on, or
it's Khalid.
Khalid? Okay.
Yeah.
Hi, Khalid.
So it's fine. It's closer to. So what happens basically when the patients are in IV, especially in patients of heart failure who have pulmonary edema, it's many a times it's very helpful, because what happens, it helps to decrease the venous return, and thereby decreasing the load on the heart.
Yes.
So
that's right.
Yeah.
So it reduces your venous return, as Ahmed actually said, and that's why
Yeah.
so use it in heart failure. The first thing it'll do, people can't breathe in pulmonary edema, you apply a bit of positive pressure, and it reduces that, offloads the left ventricle, doesn't it? Yeah, increasing. What about any other ideas? Any other things?
Also, I would think, I mean, giving a positive pressure there, especially patients with cardiac asthma, you know, so there is this interstitial fluid that would be displaced in that sense, and also improve oxygenation.
Yeah, I mean, part of it is because the alveoli is filled with edematous, aren't they? And they're filled with a bit of fluid, and so the idea is one, you drive it out a bit.
Yeah.
But you improve oxygenation because you reduce the pulmonary congestion. Yeah, and you also should put less strain on the left ventricle. So that hopefully, well, I'm kind of giving you clues here. So I'm just looking for the physiological effects. Do you use it in asthma, NIV?
And it can cause barotrauma, I guess, if you use it for a long time.
Yeah, it can cause barotrauma. If someone's got a bit of certainly if they've got bullous disease, because it's positive pressure, you put more strain on the bulla, you can pop something, and the same reason you can get pneumothorax. Okay, so you're giving me, okay, well, I was going to say, give me some cardiovascular, but let's stick with the respiratory. Anything else? It's this, who's...
I mean, it's by keeping the alveoli, the pressure we give keeps the alveoli open, and that increases oxygen exchanges.
Yeah, so it reduces any kind of shunt by getting the fluid out and reducing that distance. I mean, you've got to understand why they're getting hypoxic, because the lungs are full of fluid, and there's a greater distance also for the oxygen to travel to get to the capillaries. So by applying positive pressure, you're reducing that shunt. Yeah, so we've said that already. That's good. Any other physiological respiratory changes? Look, it's not really that different from a ventilator.
Giving a PEEP consistently might cause lung damage.
Yeah, physiological changes. Okay, so you might. What will it do to your dead space?
It will increase the dead space.
Good, right. What will it do to your FRC?
Decreases it.
Does it?
Will increase it.
Increases it, yeah. I mean, Ahmed said earlier about having, well, you and I, as we're sat now, we've all got a bit of positive pressure in our lungs, because if we didn't, alveoli would collapse. So the reason they stay open means that they must have a bit of positive pressure. I thought it was about 4. Ahmed saying it's about 3, but because we can talk and we've got vocal cords and a bit of narrowing at the upper part of our airway, our lungs are always open. They never collapse because we've got a bit of positive pressure. So, and the reason that occurs is because we've got an FRC. So by applying a bit of PEEP, we're increasing dead space, you quite rightly said. We're increasing our FRC. Any other respiratory changes? Who's doing their exam? And you've all got, I tell you what, do me a favor, everyone turn the camera on. Ahmed did ask, and I'm going to insist. Good. Thank you. Who's that? Rohide. And you've got a few people there. Marize, Bucket. They're good. That's better. It just makes it a lot more, certainly for Ahmed. I wish you'd done this earlier so we could all see, unless you were all doing something we shouldn't be seeing. Yeah, so tell me about the other physiological changes. It's the same as being on a ventilator. So essentially, it's just that it's less secure. We're just applying it here rather than through a tube.
Sometimes the breathing doesn't synchronize with the patient is not breathing with the machine, so sometimes that could also put pressure on the respiratory muscles.
So that is okay. So not a physiological change. You're talking about one of the problems with it. That's not really an issue with BiPAP. You can breathe on the BiPAP. So BiPAP is just having a PEEP at 5, and then increasing the PEEP to 15 or 20, and then dropping down to a smaller PEEP. And the difference between that PEEP and this PEEP is your tidal volume. Yeah, if I've got PEEP here, and then I increase the PEEP to 15, and then drop the PEEP again to 5 and 15, the difference is that tidal volume. And that's how BiPAP works. But you can generally breathe on top of BiPAP. It's not too bad. You can't when the patient's intubated. It's very difficult. Okay, so you've got, it causes changes, as Ahmed already alluded. If somebody had a raised ICP or a bit of a head injury, you have to be very careful because it increases, because you've got increase in positive pressure in the thorax, it also increases your ICP. But when people are on a ventilator, we kind of manipulate it so that the pressures aren't too high, or we control the CO2. We increase the dead space, we've said, we increase by increasing the PEEP. We've also increased the FRC, which hopefully improves oxygenation. What about cardiovascular changes? Anybody? Does it have any consequence on cardiovascular change? Okay, so it alters your pulmonary vascular resistance a bit. If I had a graph, I could show you, but it may increase it, it may decrease it, depending on whereabouts you are on the curve. So it affects your pulmonary vascular resistance, and it also offloads your left ventricle by reducing your venous return. It's turning into a bit of a tutorial. I was just meant to be a question, and I'm sure there are other effects. And by altering the oxygenation and CO2, you can also argue that you get a change in oxygen dissociation curve. What else can we say about PEEP? So non-invasive. Non-invasive is very useful. I think there's some paper that's come out recently about the use of NIV because we used it a lot during COVID in the last 2 years. We used it a hell of a lot. Now, there was a paper, and I'm trying to think where it was. I didn't read it, I just saw the headlines and the abstract, saying that it didn't really affect mortality or intubation rate. I'm not sure that's true. It's certainly anecdotally at Northwick Park, we used it so much, and we did save a few people from coming to, I'm talking about purely COVID now. We did certainly, by using it and proning people with NIV, anecdotally, I can say that we certainly saved a few people from being intubated, ventilated, and coming to ICU. This paper suggested that actually it didn't, but I'm not entirely sure that's entirely true, because I know we saw so many patients at Northwick Park. It certainly prevented a few ICU admissions, and people turned around, they got better. What else can we say, Ahmed, about NIV? It's a very good talk. You clearly, I loved your animations, by the way, at the beginning. It was a good talk. Any comments? Any other questions, actually? There was a paper, I'm trying to think of NIV. There was a paper, I can't remember when, I think it was New England Journal, about a few years ago, also about the use of NIV post abdominal surgery, comparing it against standard oxygen versus electively putting them on NIV. And NIV was found to have a much better outcome in terms of reintubation rates, early reintubation rates. But I don't think it affected mortality. I do remember also a paper about NIV in the use of sleep apnea and reversing AF. And what they did